We're going to go ahead and get started for this session. Once again, I would like to thank each of you for your attendance today. I'm Helen George, the mother of Will. Will was an all-American kid. He was popular, he was a good athlete, and all signs pointed to a successful young man on his way to a successful life. Then he tried Adderall to help him study in college. Before long, he found himself in a full-blown addiction. Will came to me and his father for help. We got him in counseling, but Will never received a suicide risk assessment. He was also being seen regularly in primary care. 4 months later, Will died. In 2020, the American Foundation for Suicide Prevention found that 45% of those who completed suicide were seen in an emergency department within a month preceding their death. And 38% were seen in primary care. It is with great pride that I introduce the Will George Project. Call to action here is to emergency departments, to primary care, and to counseling services. Our ask is to implement universal, standardized risk assessment screening. I'll now turn it over to Kimberly, who will serve as our moderator.
Welcome. PD AHEC is offering continuing education at no charge for this breakout session for registered nurses and social workers. To receive the credit, you must have attended the opening session and attend the healthcare breakout session too, as well as the keynote presentation later today. See the TAN card on your table for more information. You must sign in on the sign-in sheet on your table. This is a different sign-in sheet from earlier, so please sign this one as well. If you have any questions during the conference about CEs, please see myself, Kimberly, or BJ at the AHEC table. Our speaker is Ms. Jennifer Butler. Jennifer Butler is a master prepared licensed clinical social worker. She has held several key positions at SCDMH, including Chief Operational Manager and Program Director in the Offices of Suicide Prevention and Emergency Services. An expert in dialectic behavioral therapy, she specializes in mood disorders and suicidal ideations and is extensively trained in various suicide-related techniques. Let's please welcome Ms. Jennifer Butler.
Thank you. Good morning. All right, don't be afraid to talk back to me if I ask a question. So how many VIPs do I have in the room? We all know what VIP stands for. Very interested people. How many VIPs do I have in the room? Thank you, because this will be a tough 45 minutes if y'all weren't interested in this. So I'm so glad that you chose this session. We're going to talk a little bit first in just a second about safety, but I want to thank Ms. George for sharing about Will and allowing us to hear his story and the full breadth of Will, not just how he died, but how he lived. And I love this project. And so I also serve on the National Public Policy Council for the American Foundation for Suicide Prevention. So I want to thank you for furthering our mission as well. So this morning, we're going to talk about suicide prevention. And so I'm going to ask you to take off your wherever you work employee hat and put on a different one this morning, whether that's family member, friend, church member, neighbor, concerned citizen, whatever that is. And I want you, because ideally many of you have heard suicide prevention talks or trainings, right? But I want you to try and think about this information in a different context. Because while I hope that you take this back to where you work and that you implement these strategies, my real hope is that you do it everywhere. Anybody taking CPR, first aid? Yeah, we don't take it because we're trying to be like Grey's Anatomy, right? We take it because there's not always a healthcare professional, a cardiac surgeon on every corner to help us when we need it, right? I don't know if you knew that the majority of CPR is actually done on people we know and love, and not in our work setting where we may be taking it. And so suicide prevention is very much like that. It's probably going to be skills that you're going to use with someone you care about, someone that's close to you. So that's why I want you to kind of hear it with a different hat this morning. So I have no conflicts, interest, or financial disclosures to go over. I asked them to pay me in milk chocolate caramels, but they didn't. We'll take that up with Pat later. Self-care matters during talks like these. You may have been someone who struggled. You may know someone who struggled. And so if at any point you're feeling a little overwhelmed or a little antsy, please feel free to go take care of yourself. There's lots of people out there tabling that are here for support, but also physically. If you're like, I can't sit anymore, I gotta stand up, that's okay, do that too, okay? There's a lot of things on, a lot of resources available to you. One you could actually even use if you're like, I'm gonna stay in a session, but I'm really getting overwhelmed by some sort of emotion, and that's the crisis text line. I love it because you could do it right here and nobody knows. So all you do is text the word HOPE, the number 4, and SC to 741-741, or you can text 988. Okay, so there's resources available to you anytime, right? So have you ever heard of zero suicide? Some, yes. Good. So zero suicide is the foundational belief that suicide is a preventable death. And when we know better, we're able to do better in our healthcare systems. There's a healthcare framework that is being done worldwide. So the Department of Mental Health adopted the Zero Suicide Healthcare Framework in 2018. We began with our community mental health centers, and then our hospital systems, and then we did some outreach with FQHCs, with other hospital systems in the state, our other sister agencies, private practices, really because we want to be able to include everybody. I'm sure you've heard the no wrong door. Well, what we mean by no wrong door when we're talking about zero suicide is that we have a shared mission, which is that no one dies by suicide in our state. And zero suicide is a bold goal. You may go, we'll never get there. But I don't want to be the person that says, well, this many deaths is allowable. We can deal with this many. No, we have to reach for the best, highest goal, which is zero. So it's a quality improvement framework. It's a culture shift where we realize and we acknowledge that suicide prevention is everyone's role. The work that's being done here in the PD area to bolster behavioral health resources is amazing. But how do they even get to that part if they aren't actually assessed or noticed in other areas of care, right? The other part of zero suicide is that it's a no-blame culture. That when someone dies by suicide in your system of care, that we don't say, well, we do ask what went wrong in terms of what could we improve upon, but there isn't a punitive response. Why do you think that may be important? You all can shout back at me. Say it a little bit louder. Absolutely, a lot of self-blame there already. When we lose someone to suicide as clinical professionals, it changes our practice. It changes us. We may begin to be hypervigilant about other patients, but we also may start to just not engage in at all. We may freeze, right? We may question whether or not we've done something. So zero suicide really is about wrapping around everyone and taking care of everyone. And we'll talk a little bit later about the federal law that is meant for you all. That's really about how you care for yourself, because none of us are immune to having a day where darkness overwhelms our capacity to cope. We are not healthcare robots. No AI here in the room, right? We're all wonderfully human. Oh, I went too fast. So Suicidology 101. There is no one reason someone dies. There may be a culmination of reasons, and then there may be a final tipping point. Most often it is this complicated, confusing mix. And that's why it's important that we're all very interested people and we check on each other at any level of distress. And why it's important to recognize that suicide is about a human condition. Yes, those who have a mental illness are at higher risk, but it's not always about that. Sometimes it's just that you are wonderfully human. So no one who has not been there can comprehend the suffering leading up to suicide, nor can they really understand the suffering of those left behind in the wake of suicide. So when someone dies by suicide, it isn't just their immediate family that are impacted. It has this ripple effect that goes through, particularly if it's in a system of care. You may have lost a patient or a staff member or a community member that you're familiar with that maybe drove you to want to know more about this today. So one of the things that we like to look at is data. I never knew I was going to love data the way I do when I took this job. So when you look at these numbers, I want you to be very mindful that right now you're just looking at a number, but these actually represent people in distress. And we work really hard at the Department of Mental Health with our partners to collect as many different points of data that will tell us about different levels of distress. So for example, 988, which is the Suicide and Crisis Lifeline, that changed in 2020 from 10 digits to 3 digits, but it also changed in its intention. It used to just be called the National Suicide Prevention Lifeline, but you heard me call it Suicide and Crisis Lifeline, where 988 and SAMHSA have elevated the need for 988 and the requirements of the skill level of 988 call takers to be able to address any mental health or substance use crisis. So in South Carolina, last year we had 39,112 calls that went to the 988 Crisis Lifeline. Already, from January to March of this year, we've had over 10,000. When comparing 22 to 23, those calls were up 14%. We had an increase of 150% in our text messages, 15% in chat. And also we had 8,642 South Carolinians who texted the Crisis Lifeline. When I sometimes present these, I had a lady in Barnwell County that said, now, she raised her hand, she said, now, Jennifer, you're saying those are signs of distress, but you tell us to call. And now you're giving out our number saying we called. And I said, yeah, you're right, you're exactly right. They're measures of distress and hope because the resource worked. And so when you talk about it, think about it in a different way. There were 39,112 South Carolinians who received a loving, compassionate call last year, or chat, or text, right? So think about it in those ways too when we look at data. South Carolina is the only state in the country that has an interactive mental health screener. It's called hope.connectyou.org. You can find that on the Department of Mental Health website. I'm also going to share another website with you a little bit later that will have all these resources in one spot. That screener, the reason that I say we're the only state in the country is because it's answered by a live person. Working on the adult side, it's answered by the Department of Mental Health and DAOs. On the kids side, it's answered by the Department of Children's Advocacy and the Department of Mental Health. And they stay with that person through that server until they're able to link them to the level of care that's needed for them. It isn't always an inpatient stay. It may not even be a referral to the local community mental health center. Maybe it's someone who's lonely and starting to feel depressed or anxious or worried about an eating disorder or substance use issue, and we link them where they need to be. We meet people where they are, but we don't leave them there. And we carry them with us until we're able to link them to that next level. So there were 632 people who participated in the adult side last year. 89% of them had not been in therapy. And 86% of them were at acute risk for suicide. So again, resources work. This worked, but we have to do what? We have to share them. So I want you to make sure your homework assignment after today is that you share these resources. So when you look at this, this is the South Carolina 988 call volume. You'll see the calls are in dark blue at the top, the teal is text, and the orange is chats. In 2023, the youngest caller was 6, and the oldest caller was 89. This impacts all of us. And so it's important that we make sure, as healthcare professionals, we ask everyone. So when you look at a little bit more data, you can see that with the crisis text line, 46% of them are under the age of 17. DMH operates mobile crisis here in the state, and they had last year 31,334 calls. So think about that. We had 39,000, right, to 988, and now 31,000 to mobile crisis in 1 year. 3,000 of those were diverted because they were able to receive mobile crisis resources. And y'all, and I say y'all because I was born in South Carolina and raised here, when we talk to other states, they marvel at the fact that we have the system that we do, because other states may only have mobile crisis 24/7, all ages, in a tiny catchment area. Some may be lucky enough to have it statewide, but many do not. And so the fact that we're able to do that 24/7, wherever you are, the only place we don't go to is inside the hospital, because you are there. Right? But if you're in the parking lot of the hospital in distress, we come to the parking lot of the hospital. Okay? So we go anywhere. We like to say that we have more access points with the Department of Mental Health than there are the number of Walmarts, Waffle Houses, Starbucks, and post offices combined. Did y'all know them? Isn't that an easy way to kind of think about, holy moly, they're everywhere. You just look later, we're everywhere. You'll start to spot us. All right, so the interactive screening program, 81% of them were accessing DMH care for the first time. And like we said, 89% had not been in therapy. So we also track EMS calls for self-harm, because death data can be 2 years delayed. During the pandemic, it was even further. We need real-time data to see where there's issues. So we pull EMS and hospital ED data. So we track the number of suicide attempt calls, death, and we started tracking mental health trauma during the pandemic. So you can see that there was a 58% increase from 2020 to 2023. That increase was 151% for 14 and older. 147% increase for those 75 and older, and 95% increase for those 65 to 74. Again, these numbers can grab at you a little bit, but they're meant to be there to say, this is everybody of those. So 852 South Carolinians died in 2022 by suicide. 6,724 South Carolinians were treated in emergency departments with a suicide attempt, with a rate of 12.7. But those 852 were our important voices. Our friends, our children, our spouses. And so I don't want to skip over that moment because they deserve to be talked about. I love that you talk about Will, and we need to say Will's name and Jonathan. And keep them alive and keep that spirit alive. And do this for those who are struggling every single day. One statistic that's not here is that every day in the United States, there are 15 million Americans struggling with chronic suicidality. 3 million of those are children and adolescents. And that's why universal screening matters so much. So Helen told you a little bit about how many people had been seen in the emergency room before they died, but I want you to look at these stats for just a second. So those who died by suicide average 16 healthcare visits during the year they died. It doesn't mean a system failed. It just means maybe the system needs enhancing, right? That was 16 opportunities. One of the things that we've done with Zero Suicide is partner with the South Carolina Hospital Association for the Drive to Zero Suicide Award. And we had about 28 hospitals this year who were given that award. But there's still a lot of hospitals who've got to get out there doing this. And what that award does is that it asks you to do universal screening, universal training, safety planning, care transitions, that we work together. Oh, I forgot my rules. You got to do just a little dance when the ringtone goes off. I didn't tell you ahead of time, so you're good. All right, so everybody's turning their ringer off right now. So when you look at those, over half of those who had died by suicide had been seen within 30 days. This says you matter in the role to fight suicide. So intent matters, right? But also means. What is the method that has the highest rate of completion with suicide, as you may know? Firearms, yes, and attempts would be overdoses. We in South Carolina have a higher rate of firearm suicide deaths than the national average. It is important that we have these conversations. It doesn't mean that you are removing guns from everyone, or you'll see PD Mental Health Center has the locking pill bottles on their table that we distribute. It doesn't mean you're going to have somebody who needs a pill pack for the rest of their lives. But if I was diabetic and I was in an acute diabetic crisis, you would not bring me cake, right? And if you came over and I had Little Debbie's and some Bluebell ice cream and all those kind of things, you would say, Jennifer, now's not the time. It doesn't mean I'm never going to get a Nutty Buddy again. It means right now isn't the good, safe time. Love them enough, whether they're your patient or someone in your life, to tell them the truth, that you love them so much, you want to help protect them in this moment. And don't underestimate your value in talking about legal needs. In a study by the New York State Office of Mental Health in 2020, patients who received a physician's verbal or written recommendation were 3 times more likely to make safe changes in firearms storage than patients who did not receive counseling. And when you ask, you're going to have to ask about other means, right? Not just pills and firearms. But lean in. There's that song for the young folks about lean back, right? That's what it is, lean back. I don't want you to do that. I want you to lean in, okay? Thank you for laughing. My children are mortified. All right, so universal suicide screening will break our system. Anybody ever thought that? If I screen everybody, Jennifer, they're all going to be suicidal. I'll never get out of the room. Anybody ever thought it or heard it? Maybe you just heard it. Heard it. So, mental illness is a significant risk factor for suicide. Our last quarter of data, we screened, because we have universal screening, at every point of clinical contact. So if someone sees me as a clinician and then the nurse and then the doctor that day, we're all three going to ask. We're all three going to ask because one of us might give the honest answer or a different answer, or maybe they've been there all day and by the end of the day, they are feeling more vulnerable, right? So in our last quarter, we screened 18,097 people for suicide. 8.3% screened positive, 1,500. If anybody was going to have everybody say yes, we would be more likely as a system of care. So I don't say that to invalidate. It is going to take a little bit more time when you screen, but it is not going to break your system. And screening has to be done appropriately. Like you can't go, okay, Ms. Butler, you're not suicidal, are you? Right, because you're a mental health professional. Right? Or just ask in a tone that makes it sound like, I don't really care. Or maybe I'm too afraid to know the answer. Sometimes that's what it is that I don't screen because then what? Well, in South Carolina, you have a local community mental health center. And you have the 301s for those struggling with substance use. And you have our private practitioners who are getting suicide prevention training. We have to come together as a community and build the system of care like you're doing in PD, so that when our other healthcare partners, like primary care, like the dermatologist, like the dentist, the veterinarian, are asking about these things, that they feel confident they have someone to connect that person to. So universal screening will increase our liability. If I know about it, that means I'm more liable. Actually, if you didn't ask, that makes you more liable. Particularly if the warning signs were there. So again, lean in. Patients will answer questions about suicide honestly. It's actually quite rare that a patient would conceal suicidality and then go on to attempt. I'll give you an example from Charlestown Pediatrics in the Low Country. We worked with them on training them in safe side prevention, which is for primary care practices. And they called one day and said, we got to tell you this story about this young man. He called his mom called and said, he is depressed, I'm worried about him, he's not getting out of bed, he's retreating, he's withdrawing, I don't know what to do. And the receptionist just had a little blip. She was like, we can see him next week at Tuesday. And the office manager who had gone through the training said, nope, bring him in today. So he comes in, the pediatrician had gone through the training. She asked him if he's suicidal. He says yes. He says, but nobody really cares about the answer. She said, but I do. She asked about means. He said yes, that his means were a firearm that he did have access to. She asked, do you have any other plans? And he said, because she had been trained to ask for more than one means, he said, I didn't think you would ask me that. Yes, I was going to drive my car over the bridge. So he had access to 2 different means, was suicidal. That young man is still alive because she cared and asked the question and leaned in. And she said, I wouldn't have done it if I hadn't received training because it made me feel more confident in doing this with my patients. So when you're thinking about risk factors to look for, obviously if they're talking about suicide, sometimes it's a myth. Some folks say, well, if they're talking about it, they don't really mean it. No, it's probably, you ever received a party invitation, a wedding invitation in the mail? Why do we send invitations? Because we want people to come, right? We want them to RSVP and say, oh, I got your invitation. I'm a very interested person. I'm coming, right? That's what these are. These are all invitations. And they're waiting for you to RSVP and ask if they're okay. And not in the, hey, are you okay? How are you today? And you keep passing, but in the pause, take a breath, lean in, ask the question. So with crisis intervention, what we know in a suicidal crisis is that everything seems dark. It seems like it's always been dark, and it's always going to be dark. The brain actually changes during a suicidal crisis, and the ability and capacity to link to those parts that even know how to cope gets less accessible. It's like suddenly somebody put a corn maze in your brain, and you've got to figure out how to get to that coping part of you. And that's why we all, as those around them, need to act as the memory to help them think of times where they coped differently, to help them think about the future and what resources may be available, to tell them that their life matters. That's why these things matter as you sit here learning these things today. So I'm cognizant of my time. So be cognizant of your own unconscious bias. What that means is be aware if you yourself are afraid to ask the question, or if you have some personal spiritual beliefs regarding suicide that may impact the way that you ask questions, but be intentional in the way you reach out and provide that support to those who are at risk. You might say, you may feel alone and like there's no one in the world that can help you during this time. And I'm sure all you can see is pain and everything seems overwhelming. Once you align with them, bring up other ways to hope. So I mentioned I was going to tell you about a website. It's called Hopeful Minds. Has anybody heard about it yet? Don't worry, PD Mental Health out here has the business card. All you got to do is go pick one up. Hopeful Minds were the first state in the country to launch this for every South Carolinian. It is a curated, evidence-based wellness platform. All you have to do is log in and choose what county you live in. That's it. We never see, oh, Jennifer looked at an anxiety screening. Jennifer looked up a depression article or blog. We never see that. We would just see, hey, there were 6,000 people from Florence that looked at it in the last quarter. That's all we see. The reason that I love Hopeful Minds is because I can trust it. I would trust it if my 12-year-old logged in and looked at the information. I would trust it to take my own mental wellness and resiliency screening. And it's a great place for you to pull up as managers with your team and say, we're going to do this breathing exercise that is on this wellness platform. Or to give out to other people. And also, don't wait until it's a tough time to use it. Use it when you're doing wonderfully to bolster and put more money in that self-care piggy bank. So Hopeful Minds also has both screeners on it on the front page. It also has all the other resources here in South Carolina. If there's a resource that you want added that isn't on there, all you got to do is reach out to me, and my email address will be at the end, and I'll add your resource to it. Okay? So protective factors. All you VIPs, very interested people in this room, are now additional protective factors. Because you're going to take this out into the world, you're going to talk about it, you're going to talk about 90-day, you're going to talk about systems of care, you're going to say it's not a weakness, it's not a character flaw, it's a human condition, and we're supposed to take care of each other. So when we think about postvention, if you'll look at that last bulleted point, if there's a suicide every 10.9 minutes, then there are more than 6 new loss survivors every 10.9 minutes as well. On average, there are 6 immediate loss survivors per death. But what we really know is it's far more than that. It might even be, there was a religious, I don't want to say what denomination because it was here in South Carolina, but there was a religious leader who died by suicide that because of the breadth of his career, it's estimated it actually probably impacted about 10 to 15,000 people. And so remember that it is okay to take care of yourselves during these times. One of the things our office does is also provide a postvention support bag for those who lose a patient to suicide, for that immediate team, to wrap love around them and say, because it isn't something we all talk about as freely, and to say it's okay, we're here for you, here's some information, and here's just some love and self-care materials for you. To receive those, all you have to do is reach out to our office. We don't need to know who died, we just need to know how many you need. So self-care is compassionate care. Just like I want you to embed suicide prevention, because guess what? It's not a new initiative, it's not a different initiative. It is your initiative because you all are about caring for patients. And so it should be embedded in everything, including how you care for one another and your workforce. So the Dr. Lorna Breen Healthcare Provider Protection Act was passed in 2020. She tried to do her job and it killed her, said her father. This was during the pandemic. And so that law states that you all have access to resources in your workforce and that you should be accessing those resources for yourselves. So as we're kind of nearing the end, I want to just say, all of these conversations can save lives. The conversations you have with one another, even if it's not about suicide or resource, just leaning in and telling someone that the moment that they're with you, that you're genuinely connected to them. We all want to feel like we're seen and we're heard. Not, I see you in a green blazer, but I see you. And so I'm going to tell you to lean in again. Everybody physically lean in just for a moment. Lean in. Because you ever heard of like muscle memory? That's what we want. Muscle memory of leaning in. Oh, I like it. See? Little chair dancing. All right, I love it. So partners and opportunities. You are not supposed to do this by yourself. You're supposed to enlist a whole bunch of other people. Remember that this may be our faith-based organizations, our community partners, persons with lived experience. Did you all know there's a zero suicide or a suicide prevention champion sitting at that table over there on the far end? Anybody know that? Representative Williams? Do you know why I say that? Because he and the subcommittee and the full committee in the House of Representatives voted and asked thoughtful questions and expressed the need for suicide prevention training for all healthcare professionals that are licensed, like the mental health care professionals, the LPCs, the social workers, the MFTs, because we don't receive it as part of our curriculum, so it will now be a requirement as part of continuing ed. So I wanted everybody to thank Representative Williams because he is a champion. And he knows and he wants this for this area, just like you do. So hope lives in South Carolina. The other thing I love to do when I go places in the country is tell them our state mottos. Anybody know it? While I breathe, I hope. We have the best state motto in the country, I think. While I breathe, I hope. Embed hope in every step you take today, in every word that comes out of your mouth, in every glance that you give someone, every smile. Don't forget the muscle memory of leaning in. And remember, you matter too. We can't do this without you. And so we need you to be here to do it. And so if you yourself are struggling, please reach out. Thank you.
You did? Thank you. At this point, we will conclude. You can take a bathroom break and then come back in, and our lunch will be ready. Thank you.